All right. Hi. Good evening. So we're going to continue our discussion of uh, health data management. CSC 5541. But before we start, I was kindly asking if you could. I see there's only one person present, which is fine. But I was asking if you could kindly confirm if you can hear me, and also if you can. I guess if you can see my screen or something.
Yes, it's showing.
Hello, can you hear me? And I know you can see my screen because I'm logged on to my other device, but can you hear me?
We can see the screen, Doc.
All right. I don't know. It's difficult for me to confirm if everything is working just fine. So maybe a thumbs up, or maybe if you can unmute your microphone and just indicate if you can hear me, that would greatly help. Okay.
So I can hear you clearly.
I can hear you.
Test it myself. Okay, so it's working just fine then. So we're going to continue our discussion of, we're still in lecture series number 1 actually, right? And interestingly enough, when we were going through this lecture series, I hinted at the fact that I'd broken it up into 4 main parts. Okay, so the first part was idea is supposed to be Administrivia. In essence, just an overview of how the course is going to be administered. Now that we have that out of the way, I thought we'd provide a bit of context, the context of what we should expect in the course. And so what I did was I took a little bit to try and use a project that we've been collaborating with together with the University Teaching Hospitals and the University of Cape Town since 2022, okay, or late 2021, if you will. So quite a bit of time here. And it turns out that as much as we have a number of quote unquote work packages, we call them work packages at least anyway, it turns out that there are some work packages that are strongly linked to what we're doing in the course, right? Or at the very least, the work packages involve, health-centric systems that are ultimately either explicitly or implicitly used to manage data. And in fact, I think I mentioned at some point, I don't know if it's in the next lecture series or next module, or module number 1, where I hint at the fact that there's a case example that will come up over and over again, right? And I felt that using our picture archiving and communication, system would be the best way, right, of running this course. So I will introduce us to the system and maybe outline exactly how the system functions idea at a later stage, of course. So to give you an overview of this, right, and as I'm going through the work packages, I will explicitly indicate whether that particular work package involved, handling data, if you will, or managing some aspect of health data, right? So like I said, we've been collaborating with the University Teaching Hospitals and the University of Cape Town for quite some time now, and really, it turns out that one of the key thing that we've been attempting to address here is rooted in the fact that the Republic of Zambia, apparently, when we had started this project, there was work that had been done by Bwanga et al. Back in 2019, where they were able to well, they report that as of 2019, Zambia had a very, very critical shortage, right? A shortfall of radiologists. Okay. And apparently, as of 2019, there were only a total of about 5 trained radiologists working in public health facilities, ideally. Now, by the way, details of this project, documentation, and papers that we have published are available on our research group website, which you can gain access to by going to EMI, which stands for Enterprise Medical Imaging, emi.org.zm. Okay, so at your own time, I mean, if you're curious, if you want to start poking around, especially that we're going to be using one of the work packages here as a case example, you may want to poke around and see exactly what it is we did there, or what it is we are doing anyway. Okay, so it turns out that we decided to tackle this problem in such a way that we, first of all, had to identify or to understand what typically happens in the various stages of your typical radiological workflow in public health facilities in Zambia. Now, your radiological workflow doesn't necessarily, require that, or rather, it doesn't necessarily have to be specific to Zambia. Aspects. So it's generic enough that it's applicable to any sort of health facility, right? However, it turns out that there are variations in the way that specific activities, certain types of activities are performed, right? I'll give you a classic example of what typically happens when an examination is about to be performed at a typical public health facility, right? Typically, they'll filter you. They'll try and find out whether you're insured, whether you're under NEMA or something, or whether you're paying out of pocket, they call it, and all those sort of things here, right? But anyways, so it turns out, right, that what happens in your typical radiological workflow, and by the way, there's quite a bit of data generated at almost each and every stage of the workflow. Not almost, actually. Data is generated at each and every stage of the workflow. And I think what I'll do here as I'm explaining the radiological workflow, I'll attempt to explain the varying types of data, or the data at least that is generated. So it turns out, right, that your typical radiological workflow is initiated by a general practitioner. Okay, a general practitioner, and usually what tends to happen is, if you're sick, if you're unwell, and you go to the hospital, there are certain instances where the physician who's attending to you may recommend that you go and get examined, right, by radiology or something. So let's say the general practitioner suspects that you have pneumonia or something like that. To confirm, what the general practitioner will typically do is they will recommend that you go and get a chest X-ray or something like that, right? An examination, ideally. So we see here that everything is initiated, like in this particular case where we have like order entry here, right? Is where everything is initiated. This is like your stage 1. So I'll call this order entry or something like that. Or actually, it's called order entry, right? We'll go this stage by stage here. So you begin to notice that for this radiological workflow, there's a couple of things happening here. There's a broad spectrum of data being generated, or there's data being generated, there's data being stored, but also there are certain key players, right? Let's think of these key players here as being human beings. In an ideal case, in an ideal situation, the expectation is there should be an information system that is used to manage health data, ideally. Because at this stage, if data is being generated, that data is actually health data, right? And it's got to be managed in a certain way. So we start with order entry, right? Now, the idea behind order entry is simple. This general practitioner or the physician, typically they really wouldn't have specialized, right? They're just general like that. They attend to patients that may have, different afflictions, if you will. So at order entry, what the physician will do to initiate the process is they will request for an examination to be performed, to be conducted. Okay? Now, in your typical health facility in Zambia, well, public health facility in Zambia like UTH, what they do actually here is they fill out a form. It's called a request form. All right, it's a request form. Now, key piece of data here, right? The request form itself. Now, granted, we at this point we're not really, so concerned with the other data that ideally should have been generated, before a patient is attended to, if they haven't been attended to at that health facility, you've got to register them and all those things, right? That's still health data ideally. But we're just looking at the radiological workflow here, right? So stage one, or the entry, fill out the request form. And in the case of the investigating hospitals, by the way, the request form looks something similar to what I'm going to showcase to you here, which is this. I hope there's a document here in the report, because when we started doing this, I mean, there's sub-projects that have been funded out of here. So I worked with a series of students who, as part of their scope of work, we're trying to kind of build a piece of software that was meant to, among other things, facilitate the requisition, right, of an examination. So, as part of the process of building a piece of software, they actually conducted a series of studies that led them to discover that at the investigating hospitals, you have something like this. So what the general practitioner would do, practitioner would do is they fill out this form here, right? This is the request form. I mean, it looks trivial. It's not supposed to be this trivial, right? It's supposed to be complex, right? But because the investigating hospitals, in this particular case, Department of Radiology at a hospital, uses a manual process. They have not really automated this process. The request form is so very simple. So they'll indicate the patient file number here, the type of radiology exam to be performed. So you tick, in essence, the modality associated with the examination. Is it a CT scan? Is it a mammography? Is it an X-ray and all those things, right? And then, so these are the options here, right? X-ray, CT, fluoroscopy, mammography, and all those things, ultrasound, and stuff. And then you notice here there's important information that is there as well. It's like the date when this request was initiated, as in at what date did this general practitioner, this physician, issue this request. And then obviously, because there are many such requests, right, you have got to specify the patient details, right? You also have details like, I don't know if it's the senior doctor here will probably refer to the referring physician or something like that. But anyway, the bottom line here is you notice that there's actually quite a rich set of data that is associated with the very first stage, which is order entry. Okay. And to a certain extent, this data has got to be managed, is it? Obviously. And it has got to be managed for various reasons. It turns out that, for instance, one of the things that the investigating hospitals does is they generate reports, right? I think these are quarterly reports or something, where they report on how many requests did we have in quarter one, for instance, for each different modality. Very important information because it helps you plan for the future, right? In fact, in some of the work that we did with my very dear friend, Dr. Enes Obizulu, the very first publication actually that came out of this project, I hope it's there, which is this one here. We actually did an analysis, right? Is this the one? No. This is the inception report itself. I'm looking for something else here. Wow. These guys didn't even bother to. Oh, there we go. This paper here. Right, you notice in this publication, but all these publications you can find on emi.org.zm. So you notice that somewhere here, right, we report on, these are so-called radiology annual returns, right? It's a report similar to this. You only be able to generate this sort of report if you have a systematic way of managing this data, right? Because this is associated with the request made, ideally. Okay? So there's this data. Now, the input here obviously is the form itself, but it turns out that I mean, maybe if we can mention the data here, I'll just call this requisition data or something, right? For lack of a better word. In an ideal case, for this process to be efficient, because it's not efficient here, right? If you're doing this manually, it's error prone, so a series of mistakes are made. It's difficult to trace important information. It makes it incredibly difficult to actually figure out how best you can improve this process, right? But in an ideal case, you can have a health data management system. I'll call this health data management system that can facilitate the requisition process. And when it comes to radiological workflows, the system is actually called a RIS platform, right? It's called a Radiology Information System, a RIS. I don't know how many of us have heard of a RIS here, but it's quite common system here. So one of the uses of the RIS platform is it enables you to requisition for examination, right? Currently, what happens for patients to move from stage number 2, which is order entry, to the examination. And if you've been sick at UTH, you've probably gone through this process, right? In fact, now, where is Miss Mtinta? I don't know if she's there. Please, I'm going to pause at some point. We need feedback from the medical doctors in the room here, because maybe the workflow is slightly different at your respective health facilities here, right? I'd love to hear about, maybe you have systems in place that, you've automated all these different processes here. Please, we're still looking at an introduction of the course. So if you have something to say, just, let us know, and then we can exchange ideas here. So currently at the university teaching hospitals, what happens for you to move from order entry to examination is, if you're sick, it's rough out there. I've gone through this, right? My father is getting really old, and there are instances where certain things, you usually go to -op or something because of my medical scheme here, but the instances where maybe the machine at -op is not working or something, because my immediate brother is a medical doctor or something, so he works from UTH, and usually we'll go there and do these things, right? So I understand this thing intimately, not because I'm working on this project, but because I have first-hand experience. It's very painful, right? So they'll give you, if you're a patient, right? The general practitioner will actually give you that form, filled-in form, this form here. It's rough and it's pathetic, really. But they'll give you this form, and then they will tell you, go to radiology. Right? They'll just say, go to your radiology. And at UTH, I don't know, depending on which other hospital, right? Because the university teaching hospitals, UTHS has a number of hospitals, right? In some instances, if you're dealing with kids, maybe you're coming from PEDS, for instance, and there's an examination that needs to be done, so you have to walk all the way to adult hospital, something like that, right? I don't know, it's sad like that. But anyway, so what happens at UTH is they'll give you this form, right? So imagine you're coming from pediatrics. It's quite a stretch there, right? From adult hospital. It's I used to park somewhere there. Usually when I go and work from UTH, their project days, right? I'll sometimes park at the car park near pediatrics here, and then I'll walk. It's quite a stretch. So imagine you're coming from there, right? They'll say, go to radiology, which is adult hospital. And you probably walk for about 10, 15 minutes or something. And if you're sick, probably longer or something, right? And then when you go to radiology, what actually happens is, ideally, from order entry, you're supposed to be examined. But at the university teaching hospitals, what happens is you will be attended to, I think you're told to go into the secretary's office or something like that. You submit this form. And then what they'll do is, because that's such a large hospital, attending to a multitude of people, what they'll do is they'll typically schedule an examination. So there's also something like In fact, they'll tell you to first of all go and make payment or something, right? So there's a place where you go and make payment, and they'll ask you, are you under NEMA and all those things, right? Now, again, the entire process, I don't know if I can't remember if we did this. We have examples of NEMA and stuff. You see now, guys, I don't know if I have this, but they'll tell you to go and sort out issues of payment or something. And if you're paying out of pocket here, they'll probably prioritize you. There's even high cost. It's sad like that, right? When you're dealing with life or death situations, you tell people if you pay cash here, you go to they'll accelerate the whole process. Yes, life is sad like that. But anyway, so you go to process payment or something, and again, that's a manual process, right? They generate a receipt and all of that, right? But we just assume that's part of the examination itself, right? So I'll say as part of the examination, there's payment, right? And in fact, if you look at some of these things we have here, after you make a payment, I know this is not very legible here, but there's a register, there's a book. I can't really read. I don't know what these guys did here. Right? There's a book. I would really want us to look at these images. I hope they're there somewhere. There's a register that they use. It's a manual. It's literally handwritten register like that, right? Which is quite sad. I'm just going to go quickly to the project shared Google Drive, and then wow. Do I even remember here where that is? This is 2023, I think. Is it this? This is quite sad. I can't remember if it should be the one, because I see NS's name there. And what I'm looking for here is I'm looking for actual images that these guys used. Or maybe we can do a search or something and just kind of search for images. Hopefully that will, photos and images, that will help us filter. SARS, yeah. Risk management, request form. And it's supposed to be masked here, but it's not masked. Sample request form. WBS. Yeah, they don't have. It's quite sad. I wanted a high resolution image of this so that we could see what this is, right? So it's like a book here, right? It's a huge book, like what typically happens in most of these police stations. So what they're doing here is they'll be using this. If you notice here, they're telling us that the following image illustrates the following consistent entry of data, blah, 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 and stuff. So anyway, this report kind of highlights the challenges associated with this manual process. But the key thing here is there's this. I'll just name these things here, by the way, that are associated to this stage by the where they are stored here, right? So in this particular case, this is a clerk registry. So there's payment data. I'll call this. There's a clerk registry data. I'll call this, right? What else is there? So if you notice here, registration is manual, they're telling us, right? And they're highlighting the issues to do with that manual process itself. And then in this particular case, this is a radiographer registry. Radiographer registry, right? Now, in all these different instances, right? All of this is health-centric data, if you think about it. Right, so this is the sort of data that is associated with stage number 2, right? Interestingly enough, and by the way, here we should be talking about as well the roles or people or something. So you have the patient, you have the physician, something like that, I guess. And then in this particular case, the roles, you have the patient, you have the radiographer, you have clerks. I call them clerks. There are different types of clerks, right? Radiographer, like that. You have clerks as well. Can't really think of any other roles here. But the key thing here is that at this stage is where the examination is performed. Now you begin to notice that prior to the actual examination, there's a whole range of data being generated. Not just being generated. Whenever you're generating data, that data has got to be stored somewhere. Unfortunately, for investigating hospitals, this requisition data is paper-based. Is it? There's a book. So if you want to look up information, like somebody comes, no, but I was booked. A request was produced by Dr. whoever, Dr. Zulu or something. Radiology is telling me they can't trace my record. Now finding those records, because it's paper-based, is difficult, right? So they are stored in, typically they will be like some storeroom or something where this information is stored. More importantly though, as part of the examination, the crucial data here would be the medical image itself. So is it the chest X-ray, right? Is it the X-ray? Is it a CT? Is it MRI? You know, is it an ultrasound and all those things? Like what we were doing at Mainasoko with my father, right? At a hernia or something. So, you know, all sorts of things being done here. Also some medical images actually, right? You know, no, you need the ultrasound here. You need to go and do is it ECG or something like that. It was crazy. You come at, make sure you come at 7. You queue up like that, you know? I don't know when we're going to improve here as a country. But anyways, so we notice here that one of the other key pieces of data actually for a radiological workflow is the medical image itself. So this is the end result of the examination itself, because once they've confirmed you've paid, when they schedule you, come next week on Monday. When you go there on Monday, they'll give you a time slot, right? It's sad like that. And then on Monday, maybe at 10 hours, they'll conduct the examination. Usually it's not exactly 10 hours, but you're on a queue in essence. My sister-in-law, my older brother's wife, got very sick at some point. We got UTH, CT is not working. And then they give us, it was a serious issue actually. They said, no, you can go to Levy. You go to Levy, this is a serious case. They're telling you, you can come up. How? You know? So we ended up going to, is it Few Labs or something like that? Somewhere in Malua area, in Rose Park, Malua or something, right? But anyway, so there's a medical image itself. Now, the interesting thing about the investigating hospitals is this medical image. This is paper. You've seen them. They are here in this report. These are all paper-based, right? Paper, right? Paper, right? All paper-based. So this is paper. And then the medical images, there's a combination, right? I think they're still doing analog, and I'll call this CD. It's digital, but it's on CD. So this has become standard practice actually in most of these, even these private practices where you can go and get an examination like Few Labs and stuff. They'll do the examination and then they'll give you the CD. I mean, they'll give you the medical image bent on CD, the DVD, you know? And usually when you know what you're doing, like in my case, because of my computing background and also because of having worked on this project, I will insist, like I will tell them, can you please email me a copy of these medical images? So they'll send them to me for safekeeping, right? Because CDs are not very reliable, is it? They have a lifespan. They can get scratched and all of that stuff. You can easily lose them and stuff. Analog is even worse. In fact, at UTH, what they'll do is, because the first stage, after the examination comes another stage. I'll talk about this other stage, right? And typically on that stage, if they've given you some analog medical image or something, they'll put it in an envelope, right? And they'll tell you, come on this day or something, meaning that you're on the queue. So they can't attend to you right there and then. Yeah, too many queues here. Anyways, so that's the examination, right? And again, want to draw your attention to the fact that at each and every step, there is health-centric data that is being generated. Crucially, there are entities responsible for that data. They play some sort of role. We can call these entities, I prefer to refer to these as roles, right? Not really people. I prefer to refer to them as roles, ideally. Right. So this image is generated, right? The main output of order entry is this requisition form that you use as input here. The main output for this stage here, right, where you're performing the examination, is the medical image itself. Of course, there's other types of data that is generated. Okay. Now, in an ideal case, right? In an ideal case, all of this information to do with payment, this information we see manifest itself as clerk registry data or the radiographer registry data. I'll call this data, medical image data. In an ideal case, you can actually efficiently or effectively store this information by using a health data management system. And again, the interesting thing here is that I'm just going to do this here. The interesting thing here is that the type of health data management system that you'd use to store what we see manifest itself as payment data, or clerk registry data and the radiographer registry data, would still be the radiology information system. Now there's something interesting happening here, right? The fact that in as much as, if you're using an information system, in as much as you have different types of data being generated, they are linked to each other somehow. And in fact, the common denominator, you notice when we get to the end of the workflow, is always the patient. It's always the patient. And in fact, if you're using information systems to do this, they'll say one of the primary keys that you need to use is you need a unique patient identifier or something like that. And I don't know how far they've gone here to UTH. They had trouble here trying to figure out devising a unique patient ID here. And no, you cannot use NRCs, right? Or passport, because there are certain clients like babies that will not have those things, right? You only get an NRC when you're 16 or something. And not everybody has a passport, but you'd want an option of a unique identifier like a passport, because it's not just Zambians being attended to there. Okay, so ideally what these entities will do, and we'll talk about this, right, is they'll come up with, when you deploy a system like this, you come up with an internal naming scheme for a patient ID, something that is going to be unique to every patient, right? Anyway, it could be unique to UTH if you want, and I think there are conversations going on to try and see if you can come up with a globally unique, at least within the confines of Zambia here, globally unique patient ID, if you will. But anyway, it turns out that payment data, this registry data, like clinical registry data, radiographer registry data, you can automate this process. At UTH it's manual, but you can automate it and you can store this information in a radiology information system. Right? However, when it comes to medical images, because these are complex types of data, what you do is you store this information in what's called a picture archiving and communication system platform, a PACS, they call it. This is short for RIS. There's a hand up, please. What is the question? Yes, please. I see a series of hands up. I don't know if you see now. We can look at the order of yes, Miss Gift.
Yes, Doc. I wanted to ask regarding the IDs that you're mentioning. Do you mean the ID that a person or a patient will be given and they'll be using it throughout whenever they go to the hospital, or it's just an ID that is given. I'm asking so because like at UTH, like you mentioned, patients are given IDs depending on what has been requested for. For example, maybe if their samples have been collected and then they need to be run, their IDs given. So I'm not sure if you mean the ID that will be given, that will be used wherever they will go. Maybe when they go to a different hospital, they have like that specific ID.
No, I'm actually referring to an ID specific to UTH. So last time I checked, actually, ideally, UTH is supposed to have a single ID for a patient, right? Because people get sick all the time. So I may get sick, kind of like in the year 2026, for instance. There's a possibility that I'll get sick again, right? A couple of months from now. When I go there, I shouldn't be issued another patient ID. Should be unique. In fact, at Minor Soko, they call them they call them MRN numbers or something. When you go there, when you are being attended to, the first thing they'll ask you, obviously, is what, are you on a medical scheme? In my case, I'll just tell them, yes, Amanda Unzalaro, okay? What's the patient, or what's the MRN number? I think it's medical record number or something like that. When you give them that number, right? And Minor Soccer is slightly more involved than the invest teaching hospitals here. They'll check into their system and then they'll say, oh, okay, can you confirm the names of this patient or something? And then they'll tell you, go and get vitals or something. When I'm taking my father there, say, go to this place and you go do vitals or something like that. And when you go there, in fact, at each and every stage, right, they'll ask for that number. Depending on which department, at Minor Soccer, they're called departments. They'll ask for that number. But guess what? When you go to UTH, right, you've been attended to, things may have changed, I don't know. Please correct me, especially you. It doesn't have to be UTH, means other health facilities. I go to UTH, I'm attended to by a general practitioner, and I'm told go to radiology. When I go to radiology, right, they won't even ask for my patient number or something, because there's nowhere to look for my details. In fact, if I've been to UTH before and they've examined me, it's difficult for them to even check, what sort of medical images were generated or associated with me or something like that. So the ideal thing to do ideally is each patient, each client who is attended to at a hospital is supposed to be assigned a unique patient ID, and that thing should be specific to that individual, right? You don't want to regenerate new IDs every time somebody goes to the hospital. It just doesn't make sense. It defeats the whole point of doing that. But your question is quite interesting, because you see now, I don't know to what extent we've done this, but you guys will probably, you are the experts here, right? There's supposed to be a countrywide rollout. I don't know how far we've gone here. Smart care rollout, right? There was mention here. They were singing about it, not gov.zm or something. It was all over the show here. There was mention, it's part of the strategy. Oh, there we go. I don't know. But this is for Lukulu here. Anyways, so if you're dealing with smart care, right, then this may not necessarily be just, ideally when this is rolled out, if smart care was rolled out to the entire Zambia, for instance, you'd say we want a single patient ID that is going to be globally recognizable, irrespective of which hospital you're going to. Why? Because there are times, right? In as much as I'm domiciled in Lusaka, there are times when I would travel and I'm in Chipata or something, and I get sick. You want these other hospitals, or the hospital that will attend to me here to smart care, I don't know why I can't find anything here, to be able to have a history of myself or something. There's a lot that has been being discussed in terms of smart care. I have no idea how far they've gone here. This is as recent as 2024, it's 2 years ago here. Are there any thoughts about, please, there's a hand up? Yes.
Yes. Interestingly, just today I was with someone from Ministry of Health, and we were discussing about the rollout of smart care. So what you've just mentioned is actually the plan to have it rolled out across the entire country. So where if a patient is enrolled at UTH, if they're accessing a service in Lukulu and there's smart care there, obviously that patient number will be the unique identifier because it will be system generated. Obviously, there are a lot of challenges in rolling out. Obviously, one of them being that there's a lot of infrastructure in terms of computers and all that needs to be set up. But I think the general conversation is to head into that direction now.
Thank you so much. Really appreciate that. You see, now this is what makes teaching a course like this very interesting, because you get to interact with experts, right? They're on the ground actually doing these things. Now, I also wanted to mention something interesting here, right? The importance of this health data, right? Because in as much as we're looking at radiology here, you begin to notice that there's so many different moving parts here. So many different moving parts. When you're sick and you're going to the hospital, right? At some point, you'll find yourself at the pharmacy. At some point, they will do lab tests, right? Lab tests, right? And I can't really think of other things here, but there's a whole bunch of things here. And the idea is you want to be able to organize this information in such a way that all of these different bits and pieces of data are interlinked, right? Because if you need to conduct tests for a small hospital like, and I want to argue here, like Minus Hope is quite small, right? A complex hospital like UTH, they'll tell you need to do lab tests, and they'll tell you go to this place. Go there, you have to pay, right? So it's payment records, right? Lab tests, drugs, medication, or drugs. Drugs sounds a bit off here. But there's medication and all those things, right? Ideally, all of these information is supposed to be interlinked. In fact, even the information associated with this radiological workflow here, where I'm talking about the requisitions being made, the results of the examination, the image that is generated, the medical image here, everything should be interlinked. Why? Because usually the physician who's attending to you is supposed to have a global view from all of these different bits and pieces of information, central ideally. But anyways, I'm going to continue here, right? Because I want us to understand here. So we are at the examination. The key, right here, the key output is a medical image. Now, it turns out that the third stage, we'll call this, probably other stages here, but we'll call this stage 3, we'll call this image interpretation. Again, with image interpretation, you obviously have data, you have rows, and then you have systems, right? Health data. There's health data being generated, but there's also a health data management system. In terms of data, right? It turns out that at UTH, I'm going to speak to UTH, and please, if those of you that are medical doctors, you probably have a different workflow. I'd really love to hear more about your workflow here, right? There's a very, very strange story about my uncle, who's actually visiting in Osaka, by the way. He arrived yesterday or something like that, day before yesterday. He got so sick, right? At some point, they did an examination. I think it was, I don't know if it was a CT scan or something. Up to now, they haven't gotten the results, right? He just miraculously recovered just like that, But it turns out that what he was told was that, no, the results have got to be sent to South Africa. I don't know where that story came from here, right? It would be sent to South Africa so that the results would be sent back and stuff. And we've heard stories about how, certain health facilities have, agreements. Like I know that UTH itself, Department of Radiology, at some point, we're actually outsourcing the services of interpretation from, is it Zimbabwe or something, right? So you're leveraging teleradiology and stuff, I don't know. But the data here at stage number 3, obviously, is still the medical image, right? The medical image data. But more important, right? So the medical image data is used here because the input for this stage here, is coming from the previous stage, which is a medical image, right? Just mute or something. It's coming from there. And by the way, there's another stage here that I kind of like omitted here, where you are processing the image. Sometimes processing means you are, I guess you are burning it on CD, all right, or you're printing it out ideally. But I've just combined the examination process to involve also the image processing stage ideally. Okay. Okay. So so there's that, and then we notice here, right, after interpretation, right? After the interpretation, the idea is when an examination is conducted, you have a medical image that is generated. This is used as input to the image interpretation stage. And at the image interpretation stage, what you have here is you have a radiologist, right? You have a radiologist who will open up that medical image. Typically, they use specialized pieces of software called DICOM viewers, okay? And so you use a DICOM viewer to open the image, and then they'll start reading that image, right, to try and identify potential anomalies in that medical image. And then once that is done, they will prepare a report. It's called an interpretation report. Now, there's nothing special about interpretation report. Currently at the university teaching hospitals, this interpretation report is actually created using Microsoft Word, right? So they have standard templates that they use, right? And if you're a radiologist and you're done interpreting a CT scan, you prepare that report. Now, currently, this is a manual process. In fact, when you go to UTH, right, radiology, right, once they tell you to say, come after 2 weeks for the examination is done, they'll tell you, the examiner, the person examining you, because these modalities, right, the machines, that are used to generate these medical images, they're located in different areas closer to adult hospital. So they just tell you, go to room so and so or something, and go and give them this CD, right? You go with your CD, and then they'll tell you, come back after maybe 2 weeks. The reason they tell you to come back after 2 weeks is simple. The reason they're telling you to come back after 2 weeks is tied to this point I raised earlier. Zambia has very few radiologists, right? So even those that are based at UTH. In fact, at UTH, quite the bulk of work is not done by the actual qualified radiologists. They're busy attending to some very, very serious issues. It will be done by radiology residents, is it? So if you want to specialize, if you want to become a radiologist, I think you do this. I know there's, I've forgotten the name. Enes had told me the name of the program that was introduced by Dr. Chilufi or something during Dr. Chilufi's time here, but it's part of the Zambia College of Medicine. I don't know what it's called.
STP.
Yes, thank you very much. It's STP. So you have a lot of radiology residents that will sit in the reporting room, and they rotate, right? They have, there are people that will be on call and stuff. So they're the ones that will be interpreting the medical images. And because they have a backlog, it's a lot, right? You have typically at any given point in time, because they're in different years, right? Year 1, 2, 3, 4, up to 5. Apparently it takes about 5 years for you to specialize or something. But at any given point in time, if you combine the cohorts, you find that it's not more than 30 people. Usually, last time I checked, it was less than 20 people actually in the combined cohorts. And in fact, these people will rotate, right? There are instances where they will be working from minor SOC or something, or in some instances, levy. So they're still not enough, which is why they'll tell you, come back. In fact, it's not even after 2 weeks, right? After a month in some instances. It's sad like that. Because you must understand this, right? There are cancer cases, In fact, you can look at this from the perspective of modalities, right? Ultrasound, MRIs, CTs, but then we're not discussing that here. There's an interpretation report, right? Now, currently, what they will do when they prepare this interpretation report is these people will save this report on, let's say, on their machine, right? The machines that they use right there at UTH, they have workstations. In fact, the funding we got from Google Research, part of it, we bought machines, right? And I think there are machines that are being used in the reporting room or something like that. One of the machines, I think, is supposed to be used by the clerks or something like that, right? But anyways, now this interpretation report, usually they'll print it out for you and give it to you. And the idea is when they give you that report, you go back to the physician, right? However, right? And I don't know, before I say the however here, so there's a radiologist, there's a physician, the referring physician. In fact, more to put, this is the referring physician, right? This here is a referring physician, right? So the interpretation report is supposed to go to the referring physician. Now, in an ideal case, what is actually supposed to happen is the results from the interpretation should be entered in the system. Why? So that this person has real-time access to the results. In fact, the reason why you want them to have real-time access to the results is there are certain critical cases which will require repeat tests, right? I am sick. Maybe I have a pneumonia or something, or tuberculosis. I'll be put on treatment. After treatment, for them to confirm that, I'm cured and no longer have tuberculosis, they've got to do a repeat test. And after a repeat test, obviously, you've got to look at the before and the after snapshot or something like that. And so these records have got to be linked. Now, for them to be linked, the type of health data management system that you typically use here, again, you guessed it right, is a radiology information system, a RIS. So in an ideal case, instead of saving it in Microsoft Word, this interpretation report is supposed to be uploaded in here. And you begin to notice here that having access to this data is actually quite crucial because there are other interesting things that are done, right? It's not just about making sure that the referring physician has access to this interpretation report, but also to generate reports, is it? You'd want to see, right? Are we effective as a department of radiology? And I'm sure they do reports, right? So how many interpretations, how many CT interpretations were done? How about MRIs? How about ultrasound? If you're just, saving them on your computers here, the process of your reporting is a bit error prone, right? It's not specific. Anyways, that was a long way of me trying to give us an idea, right? Of, although this is like a specific workflow in a typical health facility, but the broad spectrum of health data that will be generated. And perhaps to a certain extent, the reasons, the justification for why you'd want to use an information system for you to be able to manage the data. It turns out, right, when you're handling data, you are essentially going to be doing three key things, right? Whenever you're handling data, three key things, right? You have to manage the data, fundamentally. You would have to store the data. I'll call this data storage. And you have to access the data, fundamentally. Now, I know what you're thinking, well, but what about creating the data? Well, it's part of management, right? So management here entails adding new records, updating existing records, and rarely the case, but deleting existing records. Right now, how you add new records is different, right? Depends on what sort of data you're capturing, but they're usually predefined workflows, right? The beauty about things like sectors like health is that they're associated with workflows that have been tried and tested, right? Procedures that work. So there's a reason why the investigating hospital said that we need to make sure that before an examination is performed, there must be a request that should be done. A lot of thinking went into this, although it's not yet automated, the process itself. Okay, so you're doing this, right? Irrespective of the data you're handling, you're doing three key things. In fact, oddly enough, these three key things are applicable to other sectors. When you're looking at the telecommunications sector, they're handling subscriber data, mobile money, transaction data. Or you look at the banking sector, when you look at data that is generated in these different sectors, it's these three key things that are done, right? You need to facilitate access to the data. You need to manage the data. You need to store the data. If you look at the banking sector, right? Usually, if you use online banking, you can only go back in time, is it 180 days or something? So they give a guarantee, say we can persistently store your data up to this period of time, and then you pay extra money, they can go back in time, right? And stuff, although it's expensive to store data over a prolonged period of time. The time period is what's called retention. We'll talk about these things, the retention. And usually for the health sector, I don't know, the medical doctors, what's the retention period for health records in Zambia? Like if a medical record is generated for Lighton, he's sick. What does the law say in terms of how long that record should be kept? But guys, we should know, right? Don't we have retention? I mean, don't we have these policies at our respective health facilities where we talk? Because you can't keep them indefinitely, is it? People are constantly getting sick. I'm looking at our colleague who is at Ngungu, for instance. You can't keep records for patients indefinitely. Like you run out of space, right? People get sick almost every day here, especially if you're using paper-based record. In fact, even when you're using an information system, right? Access becomes slower when you scale up, ideally. So typically retention period, I guess, I think it's 5 years or something like that, something of that sort. If you look at the banking sector, I mean, are you going to need your bank transactions from 10 years ago? I don't know, right? If you look at your UNZA record, like right now, how long should they keep it? Well, probably they should keep it for the duration you expected to live, right? So maybe beyond 50 years or beyond 100 years, it's pointless to keep that record because you will not be around, right? To require that record. But right now, maybe you'll be an aspiring member of parliament so that you become Minister of Health or something like that. People start digging into this. This person fabricated their degree certificate. They didn't graduate from UNS or something. And then someone will come to UNS and request for a record or something like that. But anyway, I'm morphing around here, but hopefully this gives you an idea, right, of health data. Now, what I had after here were a series of some things that we've done as part of the project, but I don't know if I should be doing this in the interest of time. Maybe I'll cruise through this just to give you an idea about the project itself, because we've done a lot of work, to be honest, a lot of work in this project. All right. We started off really by explicitly indicating our focus areas. So we are focused on, our work focuses on health facilities where we know there will be modalities, is it? These machines that are used to generate medical images. And so we discovered that this typically associated with level 1, level 2, and level 3 hospitals. Currently, if you go to a health post, like Nyanje Health Post or something, there's a health post I visited at the village, at my mom's village here, which technically is my village in my culture. It was quite sad, right? A one-room structure, and it was closed at the time. You don't expect there to be an X-ray there, let alone a CT machine, right? So we're focusing on these facilities. And incidentally, what we did is, you guessed it right, we used the master facility list, right, to identify the numbers and stuff. Like it or not, this is health data, right? Well, oddly enough, it's not really directly linked to a patient or something. So in essence, we came somewhere here where we went to, you can go to facility list and then you go to facility type, right? So you'd be excluding things like a hospice, we're only interested in level 2, level 3. Can I get multiple here? Why? Level 2, level 3. Okay, I can't. There has to be a way of maybe advanced search or something. We were interested in facility type. We're interested in that. Yeah, this is horrible, is it? I've never seen an information system like this. This is horrible. But also what you can, I think one of the things we had done there is we just said, I'm going to reset this. You go to your master facility list. I believe it's been a while here. That was like 2021 was when we were doing this. It's been a long time here. But what we did is we just, you can export everything, right? You can export everything here, and then you do a filtering outside of the system, because this is a horrible system, a really oddly designed system, because you want a multi-select feature here, is it? So you get these 3,760 records, right? And then I'm exporting them to Excel here. Oddly enough, it's taking a long time. I don't know why. And then once exported to Excel, it's coming. Once exported to Excel, what you can do is you can filter this information that you're looking for. So in essence, what we did now in our case is we have these records. How many are there? There are a total of, if I look at the count from here, there are a total of 3,760 of them. And our goal was to, can probably just pivot this stuff here. Our goal was to do this, to say facility type. I'll filter the facility type here. I could have filtered them from there, but you can do a count, I guess, by facility type or something, and then you do the counting of the codes themselves so that you have an idea, right? So what we're interested in are these things here. So level 1, level 2, and level 3. So in essence, these things that are kind of like highlighted in yellow here, like this. Okay. So the total number now is this, comma this, comma this. It's about 205 or something. At the time we were doing this, which is a couple of years ago, it was like 151. Clearly, I guess the government is doing quite a bit of work here, right? It appears, I don't know how this happened here, but it appears maybe a number of other health facilities have been upgraded or something like that. Because if you compare to this paper, it's from 2022. That's 4 years ago. And we had 151. Is it this minus 151? We've had a total of 54. Level 1, 2, or 3 hospitals come up. But also, what you begin to notice is that some of these private hospitals that are increasingly popping up here, they'll be at either one of these levels, right? I'm not sure if that's a question. I thought I heard something. No, it's not. Okay. So anyways, we were focusing on these hospitals, right? For the reasons stated. And really, we went through a systematic process to try and understand exactly how, data associated with radiological workflows here are generally managed. And it was quite sad, really, right? We focused on the investigation hospitals where we discovered that it was a manual-like process. Now, the goal of the project is not really to talk about or to look at health data and how it's managed. Far from that, right? The goal of the project, is to make these radiological workflows in public health facilities more efficient and effective. Okay, so it's like the interpretation stage or the transcription stage where a report is being created. What can we do to reduce what's called the turnaround time, right? Because when you're writing a report here, the turnaround time associated with interpretation includes the amount of time that it takes for you to get a hold of that medical image, open it up in DICOM, analyze it or interpret it, produce a report. So there's some things that we are doing that are supposed to be aimed at reducing the turnaround time. Like last year, we partnered with Cancer Disease Hospital, and we were looking at how can we reduce the turnaround time, around time, right, for interpreting those medical images associated with cervical cancer or something. We focused on cervical cancer. And we actually proposed a method to automatically create the reports here. Now, there are other things that people have done elsewhere, like you're using dictaphones, right? Instead of writing the report, you're actually reading out things, yeah? As you're interpreting the image, you're reading out things, and then you do your speech to text, and then you automatically generate a report or something like that. So we're doing a whole bunch of things here. The goal is to ensure that we streamline radiological workflows. Okay. Now, the approach we took is quite simple, right? It turns out that there's this idea called enterprise medical imaging, right? So it's not really a novel idea. It's something that people have been doing over a long period of time. And really, EMI encompasses a number of key elements. Like you're looking at the content that is generated, the medical images and stuff. You're looking at issues to do with policies or governance. And then the actual strategies that you're employing, right, for you to be effective and efficient. You're looking at the various platforms that are used in this workflow. So I introduced us to things like, if you're paying attention, your DICOM viewers, right, for viewing these medical images. Your radiology information system for storing data to do with requisitions, right? Data to do with requisitions, data to do with examinations, right? Data to do with the reports that are produced here. It turns out that as part of the examination, there are other, important things being done here, like you are associating descriptive information to the medical image. So your typical medical image will have things like next of kin, right? Details to do with the patient, additional details to do with the patient, right? Not just your name and your patient ID and stuff. But so there's a lot that is involved here. It's to do with image processing anyway. So platforms, right? And I mentioned things like the picture archiving and communication system, right? Where you're storing these medical images, right? So that the referring physicians, radiographers and radiologists and other experts actually have easy access, right, to the medical images being generated. And this system is usually designed in such a way that it's done in such a way that it facilitates, it facilitates easy access, right, to information. So this is some example system that we set up, right, the PAC server as part of this project, right? It looks simple, the interface is quite all right, people can log in and stuff, but it turns out that it scales, right? It scales really well. So you can have millions and millions of records in here, okay? Health data, ideally. Anyways, but there's more, right? I focused on platforms that are specific to this radiology workflow. In an ideal case, you would want your RIS and your PACs to be linked to a facility-wide system, typically to be your HIS, right? Your hospital information system. Now, this is where the initial registration of the patient is done. You gain access to interesting information centrally. It's a centralized way to gain access to information. In certain health facilities like UTH, you have a separate laboratory management system or something like that. But I don't know, So which is why here we have a RIS/HIS, is it? Yeah. By the way, what you're seeing here is a fancy way of saying it's this workflow, but with these health data management systems, implemented ideally, right? Now, at some point, I think next term actually, you're supposed to have a very comprehensive discussion to do with interoperability. I don't know how many of you noticed that course here. But part of what we're going to be doing is looking at these protocols that are used, like HL7, the DICOM standard, for instance, right? It turns out that these protocols are the ones that will facilitate interoperability. In other words, enable separate systems, these disconnected systems that you have in a health facility, to exchange data. So your hospital information system will be able to automatically pull information from a picture archiving and communication system platform, for instance, or from a radiology information system. And this is what you want, right? If a referring physician ultimately is interested in having a broad view, a centralized view of everything. Minor Soko has tried to do this. When you go to Minor Soko with my mother or my father, for instance, it's always things like, and my dad is always asking questions here. So you go there and you say, no, I have entered in the system that there are lab tests that have got to be performed. Okay? So we go there at the nurse's bay, and then they'll draw blood, and then they'll tell you the results will be read at this point or something. And my father is always asking, so because he's used to the workflow at Chipata Central Hospital, Chipata General Hospital. He's always asking questions like, when should we come for the results? And usually the nurses will always respond by, no, the doctor will have access to these records. You only need to go and print out these things. Like we're doing some very strange tests. At some point, we had to go to, it was a horror story, colleagues here. Very sad what happens in this country of ours. You know, it's very, very depressing sometimes, right? We needed to do some tests with my father here, and they couldn't do it at Mainasoko, and so we had to go to. I remember we went to some really strange place. We had to do an HbA1c test. I'm just looking up some of this information I sent to my siblings here, and we couldn't do it from Mainasoko. Apparently, couldn't do this from there. So we went to Lassent, is it laboratories or something? That's a horrible place. Never go there. In fact, I've just been busy here. I wanted to report them to our union so that they exclude them from the scheme, right? We went there. They promise us the results will be ready in 3 hours. They don't get back to you. I follow up after is it 2 days or something? No, the machine is faulty. They're fixing it. These guys only sent the results on Tuesday. That was after my dad's scheduled appointment with the doctor. So what we did was just went to Unilabs anyway. So in that particular case example I'm giving, right? Because Unilabs is not interoperable with Mainasoko systems, what they did is they printed out the results. So we had to go with those printed out results and submitted them to the doctor. But if they were done at Mainasoko, the doctor would have a centralized view of everything. So like Dr. Njungi, she had a view of the results for the echo, the ECG, you know, the ultrasound, and all the crazy things that they do. These important people here. But anyways, so that's that here. I thought I'd mention that you know, there are a number of platforms, right, associated with this workflow. Some of them are not explicitly linked to radiological workflows, but there's an interconnection somehow. Okay. What else? You need some kind of image exchange service, right? Because, like I said, these systems, disparate systems, have got to speak to each other. Like, for instance, the radiology information system has got to have a way of linking the report generated by the medical practitioner here with all the details of the request that was made, the examination conducted, and who conducted that examination. Right? How do you link them? Well, you'd link them with a protocol, if you will, right? So there's got to be some image exchange service. Of course, you need an image viewer. I introduced DICOM viewers, and then in some instances where all of these workflows are automated, you would have some system that is used for image analytics, right? So you do a lot of crazy analytics on images. And these are things that are not done, right? Or if they are done, it's difficult. And I know it's difficult because there are some colleagues, like I know Dr. Piri, who is, I don't know if she's still at Mainasoko, or, you know, I was doing a study at some point and I had to go to they call it the library where they store stacks and stacks of CDs, right? I had to go there and manually read all those CDs. Some of them were scratched, they were not accessible and stuff. So doing analytics is difficult, you know. If we had systems in place, we'd be able to see trends, right? A rise of certain types of cancers. You don't have to wait until the situation becomes so very serious, right? If you have access to data, you can do all of these fancy analysis idea. Anyways, so we took a simple approach where we are leveraging enterprise medical imaging strategies. This is where our project name comes from. And really, we are focusing on all radiological workflows. And so we have a series of work packages. I'm not going to waste a lot of time talking about these work packages. Maybe I should focus on work packages that resulted in some aspect of health data, for instance. We had to digitalize, right, these report data and also medical images, right? And I'm not saying digitize because we're digitalizing them by reading things that were on disk, on CD. So we had these research assistants who in part, were responsible for moving everything that was in what they call the library, those stacks of CDs, right, into our PACS platform. Okay, we implemented a PACS platform in essence to automate the process of storing medical images. This is where this is coming from, by the way. And then work package number 3, we were actually trying to ascertain DICOM compliance. So it's like, if we have a situation where requisitions are done like this, to what extent can we trust this sort of information when it's associated with medical images? It was an interesting study which I can showcase some publication that we did. It's again on our research group website. I worked with Elijah Chileshe. He's now a master's student. He was doing his postgraduate diploma then. Is it this? This guy hasn't. He's supposed to have uploaded that. Oh no, it hasn't yet been published, I guess. But we did some interesting analysis, and I can go to the publications, I guess, here, the preprint, so that you have a sense of what we did. There's a whole dissertation report based on this, by the way, but so we did this sort of study. There's some nice. I can share this preprint with you if there are people that are interested in this. I guess, I don't know, but you'll notice that we did some interesting things. Elijah and myself were working on this sub project here. It's quite some. Sometimes when you do things over and over again, you begin thinking we're doing very important work, right? I still think we're doing important work. People may think otherwise, I guess, I don't know. But anyway, so we did an analysis. Look at what we did, right? In terms of the health data we're analyzing are DICOM files, these medical images. We analyzed 7,632,534 DICOM files from UTH. Okay, and what we were interested in doing is we wanted to analyze what's called the DICOM elements. Now you begin to notice that each medical image is associated with descriptive information that comprises of so-called elements. It's about 5,078 tags, right? So patient details, I'll show you something here. If I scroll down here, this is all health data, by the way. When analyzing, this is just a snippet of the elements we are analyzing, like the study period, the type of modality, the age, and all those things. And what this, image is showcasing is, or this graph really showcasing is the fact that when we did a DICOM compliance analysis, there were some elements that were missing completely, like details of the referring physician, if you notice, completely non-existent. If you look, they're all in red here. Yes, there's a hand up.
I just wanted to understand what you mean by DICOM elements. It's somehow new to myself.
Yeah, right. And we're not talk about, I'm using this as a case study, PACS, and you will see these things. But okay, so here's the thing, right? I'm gonna attempt to see if I can. I want to attempt to see if I can. Let me see if I can fish out something quickly, and hopefully I'll be able to explain these things here. I'm looking for events here and I can't find. I have to search here. This thing has evolved into something much bigger. Ministry of Health. Excuse me. Let me see if I can find MOH. There has to be an MOH thing here. We've done quite a series of presentations with MOH in this project. So I want to attempt to explain this from perspective. I think I suspect I hope the instance is still up and running. I hope it is up and running, which I think it should be up and running. Just going to, you can test it out, by the way, with these credentials, right? I want to see the credentials just to confirm, but this is a URL. I don't know if it's up and running, which I think it should be though. Maybe not, I don't know. If it's not running, there we go, it's still running. So the idea, right? Here's the thing. If when an examination is performed, right? But all of this is anonymized, and we get to talk about this thing, the importance of anonymizing this information. This is actually data from UTH, right? So it turns out that a typical medical image is what you're going to see just now here. I want to see the actual medical image here. Preview the series or something. So the actual medical image is something like this, right? I don't know if this is a chest X-ray or something. This is what is generated, right? When you say we need to do an X-ray, they'll make you put on that gown or something like that, right? They do strange things, our colleagues in the health sector, you guys. But what is generated is this. Now, when this is generated, right, embedded within this file, or this file is typically associated with important information, the image itself is incomplete the way it is. You agree with me? However, I'm just going to go back here. The image is incomplete the way it is, right? It turns out that what you are seeing there is typically associated with certain type of important data, like, I don't know if you can see, I've just zoomed in here, like the patient ID, the date of birth, the gender, when the exam was done. Important things like the institution name. Like if you look at a complex entity like the university, UTHS, a number of hospitals. When you have a number of hospitals, and each of these different hospitals will have like different modalities, right? Gone are the days when people would just have to go to adult hospitals to go and do certain exams, right? There's some places where you have this equipment, like the emergency. My brother works from emergency or something. And from there, apparently they have some of these, if it's a serious case, you can do imaging right there and then. So that's a separate hospital, right? I think it's different for adults, I don't know. So, but the idea of the institution is you want to know, is this image coming from cancer disease hospital? Is it coming from adult hospital? Is it coming from mothers and newborn? The referring physician name, which doctor made this requisition? And there's other information, by the way. So if you start counting here, these are what I'm calling DICOM elements, or you can call them metadata elements, things that help you describe the medical image itself, because in isolation, the medical image is not that useful. In fact, there are other important, I'm going to show them to you actually. There are other important elements, right, that UTH doesn't capture. Like, is this person pregnant? You know that there are certain tests that must not be conducted, right? If somebody is expecting like that. So if you see now, if I go to, I guess it's DICOM compliance or something, maybe under data, I hope I'll be able to find the looking for here. Yes, I don't know if that's a hand up, please.
Okay, just to understand, DICOM elements, and I'm not sure if I'm getting it right, DICOM elements more like baseline characteristics.
No. So they are not really baseline characteristics. They're, how do I explain this? How do I explain this? I'm trying to see. I think I gave an example last time to say, I'm going to use this example again, right? To say, DICOM is a standard, by the way, digital imaging and communication in medicine, I get. But observe, when you take a photo, right? A picture. I'm passionate about cultural heritage preservation myself, so I normally visit. My mother was worried when I was traveling to Chinsali. I was giving my mom, my dad, and my siblings updates here. I've just stopped over Chipoma Falls, and I was all alone at the falls because it was in the morning. Naku something caves or something. My mother is in the rainy season is where you have snakes or something, but this is Leopard's Hill Caves, by the way. So when you take a photo, right? Yeah, using your phone, there's something interesting there. If you upload this photo in Google Photos, for instance, Google Photos will automatically tell you things like, it will automatically know to say, this photo was taken on February 24th, 2026. In fact, your photos in Google Photos, in application, the Google Photos would be tagged by location. So it will show you to say this photo was taken in Lusaka or something like that, or at Lusaka National Park. Well, ultimately, when you take a photo, what you are interested in is the image itself, like this, right? This is what you share with colleagues and stuff. But there are instances where that auxiliary information becomes important because it helps describe the photo. In fact, in an age where in a given day, right? Like when I was at Chipoma Falls or something, I probably took more than 100 photos. Now, if you have like more than 100 photos, right? How are you going to make sense out of these photos, right? Metadata. So a photo, and I know we're not really talking about things, but a photo like this one is associated with data about data, descriptive information about the photo, right? For instance, and I'm going to copy these so that you see them, right? It will have details like, copy these things here so that you see them. It will have this sort of details. So when you take a photo, what your camera does, right? The thing that you're using to take a photo is your phone or something. It automatically embeds inside that photo. It adds important information like where that photo was taken from. So if you notice, these are like GPS coordinates, right? So I can get these things. I can get this coordinate and know exactly where this photo was taken from. Or latitude and longitude. Longitude. This is easier here. GPS, the combination. I need both latitude and longitude. And because Google Forms expects these things to be done in a certain way, I'm just going to do something else. Don't worry, by the way, in case this is appearing confusing or something, I'm trying to explain something, and we're just looking at the overview here. We haven't even, what is this now? We haven't even, what is this? What are these guys doing here? They're doing a lot of crazy things here, right? I'll use DeepSeek, I guess. I'll just use DeepSeek. Better that way, I guess. I don't know. So if you, why do I have to log in again? I don't know. Sorry, this is taking a while here. If I wanted to figure out where that was, right? I'll go to Google Maps, but Google Maps expects you to maps.google.com. What Maps does is it expects you to format these things in a certain way, right? What is this? What is happening to my... I have no idea what is happening here, right? I think there's something wrong with my... there's something wrong with... okay, I'm gonna do this. I'm gonna copy this, my account, convert to Google Maps format. I think I have... and I can use this, I guess. I don't know. Hopefully this is horrible. How about cloud? Looks like everything is just falling apart here, is it? There we go. Cloud is much more friendly here. I don't even have to think about this prompt here. Just convert to Google Maps format here so that we can kind of like see. Wow. Let me see if this will work. I don't know why I'm obsessing on this, because I'm just trying to give an example. This is the easiest way of explaining what DICOM elements are, right? So the standard that is used to make available, the standard used to generate those medical images is called DICOM, right? Digital Imaging and Communications in Medicine, DICOM, okay? So in this particular case, right, I can check using this information from the photo itself, right? These are what I'm calling metadata elements. So there's an element that says GPS position, right? And using this GPS position, I can say, well, where is this location, right? And what this thing will tell me is oh, you are somewhere near Leopard's Hill Caves or something like that. You notice here, Leopard's Hill Road is somewhere around here. Right? There's a Leopard's Hill Bat Cave somewhere here, was where I took that photo from. I think this was the entrance to the cave itself. I don't know if people have been there here. It's a nice place. But you see, for a picture, right, we have about what, if you're counting here, 90 elements, right? GPS position, the light value, you have things like the shutter speed, the megapixels, right? So they'll tell you the phone you're buying can take photos, using 12 megapixels or something like that, right? The image size, the resolution of the photo itself, so that when you do something like this, you'll find that it's 4,000 by 3,000 or something, right? If I do identify like this, right? This is the resolution. All of these things are part of the metadata. Now, this is an image, right? A photo taken using your phone. It turns out that that medical image itself can be viewed as a photo, because what you see in that medical image is something similar to this, right? It's an image, ideally. But what your modality, like an X-ray machine, does is it enables you to inject a lot of information. What information is that? Observe. It's information like these things here. These are the tags I was talking about. And we classified them together with Elijah here. I was working with Elijah today. Pretty, when you have project money, you can hire smart students like that. These are the elements here. Now, what you notice if I start searching for patient, right? There are tags to do with patient here, right? Not patient sequence here, but I want to get to the stage where we have patients here. Look at this, patient name. So the DICOM, together with the image, similar to like a photo which has 90 values, a DICOM file will be injected with this important information, like the patient name, patient ID. I don't know what issue of patient is. I would have to look up the specification. Type of patient ID, right? Is it NRC and stuff, all that? Patient birth, date of birth, birth time, some weird metadata elements, right? And our colleagues elsewhere, it turns out that you're able to take advantage of quote unquote precision medicine if you're precise in the way you're capturing this health data, right? The patient gender, primary language, right? All of these different things here. I don't know what patient size is here, right? The body mass, there we go, right? The body mass index of the patient, the weight, their address. Why? Because in some instances, in some serious places, right, they call you, right? If there's an emergency, they don't call here. I don't know if UTH calls it. It's sad. My father was surprised. He's like, when they were coming with my mom for his scheduled appointment, he's like, I was surprised. They called me when we when we were on our way here to tell us that our appointment has been moved from the afternoon to the morning. And he was jokingly, and he was serious, but he was jokingly saying, Chipata General Hospital can never call you. They will never call you, actually. And they never called him because his procedure, he had a hernia. His procedure was supposed to be originally performed in Chipata, but we felt it would be best done here, right? So he said, they never called me in Chipata or something like that. You move on, right? Like that. But anyway, so these are what we're calling the DICOM elements. I don't know if I've answered your question. Rich data set, right? Look at, yes?
I've had my hand raised. I just wanted
Oh, sorry, I didn't see your hand. Please go ahead. Yes.
to clarify. So maybe just to add on Moria's question and maybe to understand the explanation that you have given. So the DICOM elements are basically more like descriptive information of a particular image.
Yes.
Okay. Thank you.
Excellent, actually, yes, that's exactly what it is. Now, when you're talking about the descriptive information about a particular image, right, I want to say we're going to use this as a case example. By the way, one of the data we're going to be looking at is DICOM data. And I'm taking advantage of the fact that you are supposed to have an elective to do with imaging, right? So that you understand this imaging, and I'm going to bundle some of these things in here. You see, if you look at an image itself, you can describe that image relative to what? The referring physician. I don't know if there's referring physician. There has to be a referring physician somewhere, right? The details of the referring physician. And you have a lot of details, right? It's not just their name here. Their address, you know, their telephone number, their ID, right? So you're looking at, first, it's the crucial bit here is the patient-centric details, right? So you can categorize this information. The physician, details about the physician. What else? The operator. I'm sure there's operator or something here. The operator is the person who is doing the examination itself, right? Operator name and all those things, right? So there's operator. You have the, I don't know if they have radiologists or something. I don't know if they would have the radiologist details, probably not here. But the reason why you'd have the operator is sometimes you want to make a follow-up, right? And if it's a large and complex entity like the UTH, making a follow-up is easily done by referring to this information, this rich information. In addition to these things here, there's details of the actual machine or the institution anyway. Institution. Right? So the name of the institution, Cancer Disease Hospital, Adult Hospital, right? And all those things, right? And there are also unique codes that you can attach to these institutions, if you will. Anyways, but also the machine itself, right? The modality, the version, because if you're using older machinery, for instance, you can easily explain some of the things. So details and modality or something. So you notice here, compared with metadata associated with these photos we take using our phones, about 90 or so, less than 100, we'll say, for a DICOM file, you are injecting all of this information. How many elements or how different ways of describing this? 5,000 or so ways. This is what we have here. When I was saying we did this study, we were analyzing 5,078 elements using this standard here, the 2024 standard. And so what we did was we analyzed 7 million plus, right? 7.6 million DICOM files. And we had some really interesting results, right? That are supposed to feed into policy here. You know, we had interesting results, you know, presented from the perspective of different types of modalities, for instance. I can share this thing. I mean, there could be bits and pieces of this, I guess, this paper that you can understand or something like that. But anyway, so we did that. I'm gonna go back here and just go to that's work package number 3, right? And then in work package number 4, we remember I said everything at UTH is manual. So we're working towards building a radiology information system that will be used by Department of Radiology as a starting point. But the bigger picture is, you know, this can be adopted in all health facilities. You know, there were a couple of conversations that had started and stuff, but we've stalled a little. We're trying to see if we can revive these conversations, I guess. And then nothing to do with data here. Work package number 5 is we conducted a study on the awareness of integrating AI, right, in radiological workflows. We just wanted to find out perceptions and awareness levels. There's a whole paper that was presented by dear colleague, Dr. Chut at MICA 2025 last year. So Dr. Chut traveled to South Korea or something together with Elijah to go and present our work there, right? And then I've been working with a student, really smart student, Malaysia. By the way, if you want to listen to what my student Malaysia and I have been working on, oh my goodness, there's a, I don't know how many of you have bookmarked and you should, right? You guys are not like the data science guys who are doing a professional master's. In part 2, you do research, right? Now, it may not really be so technically inclined like what some of the things I'm walking you through here, but my advice to you is you must you must start attending these sessions early on in the process. So there's this calendar I shared with you, is it? Postgraduate research calendar. Like tomorrow, there are a series of these presentations. You can pick and choose which ones. I mean, these are nothing to do with health per se, but my student Malaysia, if I order these by schedule, my student Malaysia is going to be doing his presentation on the 25th of March, right? So he's going to be talking about AI medical image interpretation. So, but also you can anticipate what he's going to be talking about if you wish by going to our research group website, emi.org.zm, and then under publication, pay particular attention to this work by Malaysia and myself and the other colleagues where these guys have not uploaded, but why? I'm looking for Malaysia, Muzuma, Gabriel. Wow. How? But I know it's on the Data Lab website anyway. So I'm just going to go to all publications. Malaysia. So this work here, right, where he explains part of what he's been working towards. So what Malaysia is doing is what he's been doing for his thesis. He submitted his thesis for examination. Is he was trying to explore, semi-automated interpretation techniques, right, in resource-constrained environments, right? So what he was doing is was building. This is work package number 6. He was building AI models that are meant to. Remember, I mentioned that at this workflow. Sorry, there's quite a bit here. At this stage of the workflow here, a radiologist will start reading the medical image using a DICOM viewer. That is time consuming. So what Malaysia is saying is, in his work, is we can use artificial intelligence to build models that mimic what a radiologist does. But we're actually using what's called a human in the loop approach, right? Because we know that these machines can make mistakes. So you still need a human being to verify what the machine has done, right? So what we have in this paper, at your own time, you can look at it, I guess, I don't know, is he talks about the implementation. So he built 2 types of models, right, as part of work package number 6. There's a localization model. So there's a classification model. And what you do is you feed it health data. Health data called what? A medical image, a DICOM file, or DICOM file / image, right, as input. And what the classifier will tell you is to say there's a likelihood that this is associated with pneumonia. So instead of having a radiologist open up this DICOM view and start scanning through this, what is wrong with this? We're saying you can build a model. And we're not saying we are focusing on radiologists, right? Because if you ask Mtinta here to say when patients go to Ngungu or something, they're not going to wait for a radiologist, because a person like Mtinta has been trained to read, right, some of these images. I mean, complex images, maybe perhaps not or something, but if you've passed through med school, they've taught you a bit of radiology and you know how to read an X-ray or something. So they probably do these things. So hello? I'm not sure if people can hear me here, right? Because I don't know if I need to engage or something.
We can hear you now, but
Oh, okay. Yeah. So I was saying, I was explaining what Malaysia is doing, and I was asking, say, for the medical doctors in the class, right, enrolled into this course, I imagine you guys interpret certain types of images. Certainly you interpret X-rays, right? I don't know if you do CTs as well, or MRIs, right? Ultrasound.
Just X-rays.
Just X-rays, right? So we are saying for people like you, right? Because your core duty is not to do this. We've built software for you. We can build software for you, right? Like what I'm explaining here, right? So on your computer, you just fire up the software, and when an examination is conducted, the software will do something like this. And there's nothing novel about this, really. But anyways, it's simple stuff. It's not that difficult. But so it's a classifier. So this model, the first model, uses this health data called a DICOM file, and then it outputs, right? Is it pneumonia, yes or no? Or pneumonia, not pneumonia, if you wish. So this is the first model, right? The first model. So in terms of the models, oh, this is the classification model, right? The other model is a localization, right? So what it does is going a step further. It's saying, well, sure, we can have an image, a DICOM file, and then this model tells us, oh, it's pneumonia, it's not pneumonia. But how does a general practitioner or a person using this model verify, right? So it's a localization model where the other model shows you, it draws bounding boxes, these yellow bounding boxes here, to say the problem is here, right? So that you focus on that or something. So that's what we did as part of work package number 6. And then for work package number 7, it was responsibility of our colleagues from the University of Cape Town. I'm working with a very dear friend of mine, Dr. Zola Maklaza. We became friends when I was in graduate school myself. All right. So what he's working towards is, remember we said the other health data you work with is what? The reports that are generated by radiologists. Well, his obsession is, can we automatically create those reports using templates and all those things? Ontologies is his specialty. Anyway, so what comes next are just, kind of like an outline of these work packages, the things I was talking about, the things that we did. So I'm going to skim through this, the PACS platform, in this particular case, showcasing the DICOM elements here. This was the analysis of DICOM compliance, so the medical images at UTH, right? These are some of the results, right, that we got. So analyzing health data from how many different perspectives here. Implementation of the radiology information system, right? And then our survey on AI awareness. Again, I'm happy to share, if you're not data generated here, but if you're interested in this sort of stuff, we have the whole paper it's supposed to be published soon, I hope. There's a publication here where we launched a nationwide survey, and this work package was being spearheaded by my dear colleague, Dr. Peter Chubuta. He's a radiology resident at the University Teaching Hospitals, in the Department of Radiology at that hospital, right? But what we did was we conducted a survey. It's not really health data, but there's some interesting results associated with AI awareness here, by the way. So I'm happy to share these things if you want, because they're not yet on the website. And then interpretation, right? This is what I'm talking about here. There's quite a bit of work we've done tied to work package number 6, right? Semi-automated interpretation. I've worked with a total of 2 students, funded students on that project, right? The one student was building software to be integrated in your PACS, right? That is supposed to use these AI models, and then the other person was building the models themselves with Malays or something like that. So quite a number of things that we have done here. And then there's report generation. Now, I want to pause here and maybe just ask if there are any sort of questions before I want us to get to a stage where I guess I'll just kind of introduce. I want us to get to the end. I think we can get to the end. I want to introduce the course. The themes are going to be, I don't know if I have them here. The themes, I'll have to re-download them. The themes, and then we can look at the other part. I don't know, maybe I should skip the other part also. No, this is no. Wow, I don't know where that is here, but I think this is what I wanted. Okay, so if there are no questions, right? Now, I want to talk about this at some point here, but I want to hint at something here. The fact that yes, is that a question? Yes, I think Ishmael has a question.
Yes, Doc. Just a quick one. Is this session being recorded?
I am trying to record it. Yes, so it is being recorded. I will share. You know, I'm a bit behind. I was supposed to have shared these things. I promised by tomorrow I should have shared all the recordings and all the materials used so far. So yes, it is being recorded.
All right, thank you.
I share this. Yes. Yeah. Let me see here. I want to. I know I made some changes, which is why I want to shift to the other thing here. I'm just going to shift to this, I guess. Yeah. So this is what we did in this kind of study here. And I don't know if this is not actually the one. I'm downloading the wrong thing. This is the one. This is what I wanted to download. I'm messing up. I made some changes, brief changes to this. So now that I've kind of like contextualized this, right? I want to remind you about something we discussed when we met last time. The fact that we are supposed to work towards certain key learning outcomes. But what you notice with these learning outcomes is that the golden thread is tied to data. Now, we'll talk about this later on, but the thing about data, it turns out, is that data on its own is not that useful, is it? We generate data because, or we capture data, and we store data because ultimately we're interested in extracting information, okay? And when we extract that information, it turns out that the information will then lead us to a situation where we kind of like derive knowledge ideally. And really, if you look at this pyramid structure here, there's mention of the fact that you start off with data and then you move on to information, right? There's a bit of meaning, so you combine different data aspects and you derive meaning. And when you have that meaning, you get knowledge, right? That knowledge can be used to make decisions or judgments or something. And then at the top here is you have wisdom or something, a shared understanding, if you will. I'm going to talk about this, kind of in the next lecture series. It is there, but in essence, this course is aimed at getting us to this stage, right? This stage here, where we are supposed to, So the course provides a comprehensive, introduction to the theory practice of health data management, which is a fundamental pillar of modern, day health informatics. Then we're giving examples here of some of these, health data aspects we're talking about, right, or systems, if you will, like electronic health records, like SmartCare, for instance, right, or medical images, which we're going to use as a case example in this particular case here. So in essence, in the course, we say that we're going to explore the entire data life cycle from the very beginning, where you're collecting data, right? Remember we said when you're dealing with data, right, or health data management systems, they do three key things, right? They facilitate access to the data, management of the data, and storage of the data. Under management, I mentioned that one of the things you're doing is you're creating new records. So data collection, right? Storage, retrieval, cleaning. Before you actually add data to the health data management system, you've got to make sure that you remove all the debt, right? You pre-process. And then you also have got to figure out how you're going to disseminate that information, all right? So that's what we're working towards in this course, right? And in terms of the key things we're working towards, is, I went through this where you're supposed to get to a stage where you demonstrate a comprehensive understanding of the health data life cycle, right? And key principles of effective data management to identify and deploy appropriate electronic data collection systems. You're supposed to look at some examples of such systems, be able to contextualize complex health data in relational terms, and design normalized database schemes, right? The reason why we're using PACS as an example is because behind it you have a relational database management system. And crucial to a relational database management system is this notion of relational algebra, right? Or relational algebra. So the data in your database is organized as relations, right? There are relationships that exist amongst the different data pieces. Okay, like, so for instance, you have maybe a table that will say, you have a patient table, you have a physician table, right? You have a modality table, and there are ways of linking data in between all these different relations. These are called relations or tables, if you will. Anyhow, also, you should be able to apply SQL to create, manipulate, and extract data views from large relational databases. This will make sense when you start looking at SQL. You should be able to analyze and implement your ETL workflow, right? Extraction, transformation, and loading. The process you go through to collect data or extract data and then load it into this data store. Anyway, you should be able to apply data cleaning and quality assurance techniques to address real-world challenges, cleaning up the data pre-processing before you actually load it into your data store, and then also be able to evaluate data governance principles, right, to ensure compliance with ethical standards and legal frameworks. And I mentioned that in as much as we want to look at international standards like HIPAA and GDPR, but we also spend quite a bit of time looking at our very own, because that's the only piece of legislation we have, is it our very own Data Protection Act of 2021. Okay, and it turns out that throughout this process, what I'll be doing is I'll be using this PACS project we worked on as a recurring example. And my hope is that if we're using this same example to discuss these different aspects, it will be a lot easier for you to understand what we'll be doing, right? So this will pop up over and over again, over and over again. And in fact, I'll be sending out a reading list so that you can already find time and look at our paper, which explains how we built this PACS platform. It's a very nice starting point, okay? So we use this as a case study to explore how principles and techniques we learn are applied, right, to solve real-world, health data management challenges, ideally. Now, our plan is for us to get to a stage where we have these learning outcomes, ideally. We work towards these learning outcomes. I'm going to propose that we break apart what we're supposed to be doing here into modules. And I'm calling them themes here, but these are modules. So in our next lecture, we're going to have a discussion of module number 1, which is the health data lifecycle and governance. And the things we'll be discussing are things like the data lifecycle, okay? Principles of effective management. Yeah, so what exactly do we do to effectively manage health data? Issues to do with data governance and compliance. Unless if things have changed here, we don't have dedicated legislation that outlines exactly how we should be handling data. And I deliberately was asking the medical experts in the room to say, what is the retention period of health records or health data? Because I know I've had these conversations with my colleagues at adult hospital, for instance, and this is something that hasn't really been thought through. I think there are guidelines or something, but there's no legislation really. If I go to, I was sick when, there was a time when I was unwell. Well, I was seeing a dentist, right? Not long ago, towards the mid of last year or something. I'm due for my annual checkup here. And if I was to go there and tell them, say, I'm looking for my records, the medical images that you got here when you were feeding my tooth or something like that, they probably deleted those things, right? Why? There's no legislation that would compel them, right, to ensure that they comply to, whatever piece of legislation will be there. So what we have currently in Zambia is something that is too generic. In more progressive countries, you have specific legislation specific to health, right? Unless if things have changed here, please, the experts in the room, you can correct me here. But last time I checked, this was the only piece of legislation that we can latch onto. So we'll look at this at length, ideally. And then in theme number 2, module number 2, we'll look at electronic data collection systems, right? So in essence, tools for field and clinical data capture, ideally. There are a number of options that we can possibly look at. In the interest of time, we'll probably just look at ODK, the popular open data toolkit, right? And then we'll look at the practical applications, right? In theme number 3, or module number 3, we'll start looking at how data is organized in these health data management systems, right? So ideally, it's stored in a database, right? So how do you organize data in a relational database? How do you design a relational database management system, a relational database ideally? Afterwards, once we learn how to design this, how then do we add records to the database itself? All right. And how do we extract? How do we read records? How do we update records? There's a language that is used, right? It's called SQL or SQL. It's a structured query language, is standard. And so we'll learn how to write SQL statements here, like our select statement to read data, insert statement to add new records, update statement to change, to modify records, delete to page records, right? You rarely page records. Anyway, and then as part of SQL, you have two categories of SQL statements, is it? There's so-called DML statements, data manipulation language, right? DML, and data definition language, DDL. So they select, insert, update, delete, you know, those are DML statements. Whereas your create table and all those things, or alter table, these are DDL statements ideally. So look at that. And then we'll look at how exactly, because this case example I was showcasing to you guys, I don't know where it is here. It's gone now. This, I have so many things open here. When I was looking at it's probably here somewhere. It's gone. It's fine. We'll find it some other time or something. But when I was showcasing the medical image or something, the idea is we want to see how we can query data, because the data that is in here, the data that is in here, this is in a database idea, the metadata, right? It's in a database. So we'll be querying the database, writing SQL queries to see exactly how we can explore the data located in there, if that makes sense. I don't know where we were here, but that's theme number 4. And then in theme number 5, we'll look at how exactly we build these extraction, transformation, and loading workflows, right? How we take advantage of this. So we'll study really the ETL process idea. And then finally, we'll have an in-depth discussion of how we clean data, right? To facilitate quality assurance ideally. You know, when you're collecting data for the first time, it will have a lot of noise. So what do we do to that data to clean it up, right? To pre-process it ideally. Okay. So that's our plan for the course ideally. I wanted to give context. I know it took a while, but I'm hoping that this holistic view here of a specific area of health data, I guess, of health, gives us an idea of the steps we're going to follow to do this. Okay. So beginning the next lecture series, we're going to have a discussion of this theme number 1, which is here, the life cycle and governance. Yeah. Anyhow, now what follows next, right, is I don't know if there are any questions here, but this is 2005 here. I wanted us to go through something because some assignments, and I think we can finish this actually. We will do this. There are some assignments, reading lists that will require that we discuss papers or something in class. So I think we need to discuss this. Yes, Ms. Champo.
I'm sorry, Doc, for taking you backwards. I didn't capture theme number 5.
Yes. Theme number 5 is building the extraction, transformation, and loading workflow. I shall I'll share these slides actually today, actually, right after class. I'll just send a link or something like that. Is this fine?
This is theme number 5?
Yes.
Or
This
they're
is
in two sets. Oh, okay.
no, it's a continuation. So everything couldn't fit on one slide. So I have 12 of 2. There's 1 of 2 and 2 of 2. It's the same thing.
Can we project 1 of 1? I didn't seem to capture that.
Oh, yes, this is what you mean 1 of 2. So because there are 2 pages, so this is page 1, 1 of 2, and then there's 2 of 2. So it's like page 1, page 2 for the same thing.
Oh, okay. All right. Thank you.
Yeah. I'll share this slide deck also. Okay. So there's because of part 2 and because of how this course is structured, and I'm still trying to think of how we're going to do these paper reading sessions here. Maybe we'll present them in class actually to be easier that way. Because if we say you turn in as part of a paper reading session, you just turn in the if you just turn in you write a summary of a paper, we know what people do, right? You just go to a chatbot like Gemini or DeepSeek and you just say, write a summary. Right? In fact, you just copy paste the the question in the assignment or something. And these tools are nice when used in the right context or something like that. I'm talking about the AI tools here. Maybe at some point we should have the conversations around that. But so I thought we'd have like a part 2 where we just remind ourselves on how to read a paper, right? I'm assuming we're going to have paper reading sessions and we'll present them in class. So the plan here is, because there are quite a number of us, we try and see how best we can split ourselves so that we have these presentations for everybody at specific points and times, right? In class or something, it would be easy. We'll try and figure out something here. In the past, what I've done with courses like this is you'd write a summary and then you submit it as an assignment, but it won't work. Now, I just wanted to start off here that when the time comes for us to start doing these paper reading summaries or something, readings and paper summaries, you want to take advantage of certain types of software tools called bibliographic managers or bibliographic management software tools. I don't know if people have heard of Zotero, Mendeley, or Jabref, for instance. There are quite a number. RefWorks, there are quite a number of them, right? And what these tools do is they help you manage your bibliography. And you can do other interesting things, like you can annotate and stuff. And I know the world has changed here, but you can also use them to automatically insert citations and generate references automatically, right? So the idea behind this is, what I'm talking about is something like this. And I have a bibliographic manager that I use myself because I use a lot of Google Docs, right? So what I would do is observe if I'm writing a paper, right? One of the key things I'll have to do is I'll have the different sections, for instance, is it? I can abstract, your abstract, your introduction, you have your related work or something, you have your methodology, standard stuff, like results, discussion, conclusion or something like that, right? Now, when you're writing this work, let's say we are discussing, let's say the enterprise medical imaging in Zambia project was initiated in 2022 or something and stuff. Work done has focused on radiological workflows and has included implementation of packs and RIS platforms or something like that. Now, what typically happens is if you're writing something like this, is you need to cite this, right? So you would obviously figure out where the EMIZ website is. Like EMIZ here, you cite, right? And when you're citing, they'll tell you, well, you must use APA or Upper Star or something, or Chicago or something, or Harvard referencing and stuff, right? Or in my field, computing is like SCML referencing, IEEE and stuff like that. Well, the bibliographic manager is going to be attractive for you when you start writing these things, because for those that didn't know, right, you can automate this process. So in Google Docs, I use an extension called PaperPower. So with PaperPower, all I do is I will activate it like so. Right, to appear in the right here, there's a panel here, PaperPower. And then I would say, if you know this, I mean, I'm just trying to provide context. In here, I would say, I want to cite this, right? Zoom in here, so what is this? I want to cite this, right? So something like this, I'll come here, under project, and I'll just say cite. Okay? And the thing will pop up here. And then what else? Work done has focused on radiological workflows and has included implementation of packs. Now, implementation of packs, we know in our case that we have work that has been published under packs. So identify where that work is published, right? We just look up the author. In this particular case, one of the authors is Lighton. And then I will go to his Google Scholar profile or something like that, and then try and see if I can find this picture archiving and communication software thing here. And then I'll look at all these 8 versions here, and then I'll choose the one that takes me to the publisher page. And in here, I'll just copy the what? I'll just copy the DOI, right? The digital object identifier, which is this thing here. I'll copy this, and then I'll go to PaperPower here and say, I want to cite work done under packs. So come back here, search like that, and then I just work here. But I'll come here under packs, or just do this here and then just cite, right? And I can sanitize this, I can clean it or something, right? Something else I will do is to say, write this in such a way that additional work has resulted in the implementation or something of AI-based tools like that. Resulted, additional. I'm trying to get this or something. So I'll come here and resulted. What is this? Resulted, additional, like that. Has, oops, has, like that. So I'll come here again and I'll do the same workflow here. Come back here and look at like work that I want to cite is, oh, this is to do with AI and this is to do with AI or something like that, right? So again here, I'll go to, I guess you go to where this work is, which is again on Springer. I'll scroll down and then I'll just use a persistent identifier like this one, right? You know, come here. This is a long way to the mountaintop here, colleagues, but you know, this is enough also. And then I'll look up this and then I'll say, I want to cite this, right? Now, the idea behind this, right, is you're not manually adding this, is it? You're not manually adding this stuff here, right? Once you're done here, you'll have like your references section like that. And then you just say, I want to generate this. Is it? You come here and then you say, in fact, if you notice here, I don't know if you can see here where there's update here. There's this drop down where I can choose the citation style, right? So APA, Chicago, MLA, Nature, plus my field is IEEE. I can search for more citations here. I can search for more in here, IEEE. It will pop up like this, right? But we just use APA here. And then I'll just say, observe what happens here. I'll just say, we are going to, I don't know why this is, we are going to update citations. And what will happen is right at the bottom here, when I just click that update citations, right at the bottom here, if this has worked, I don't know if it has worked, it will automatically generate these citations, if you notice, right? I mean, so that's I don't know why this is taking a while here. That's the essence of this. And in fact, I can change this if you notice here. This is using, yeah, this is kind of like using, it's using the citation style that and referencing style that I've specified here or something like that. Now, PaperPow is an example of a bibliographic management software tool, and you can clean this up, right? Because you notice that some things here are not properly formatted here, like this website. It automatically picked the wrong data here, so I'll edit the data, metadata like this, and then I'll just tell this thing that actually the name of the website here is. I have to sign in here. I don't know if I'll be able to sign in here because it appears to be a problem with my. It's very sad here with my user. If I say continue with Google, I think it's failing for some weird reason here. Single sign-on was failing, if you notice, when I was trying to do that. There we go, it's failing. But anyway, the idea is you can edit the data like that, right? Now this PaperPow is a bibliographic management software tool because you just don't use it to automatically generate citations like that, but you use it to manage your bibliography, right? And managing your bibliography becomes a crucial part, right, of the research process here, because you will find yourself reading a ton of things. So what are we saying? We are saying that you have a series of bibliographic management software tools. Like Mendeley can be installed locally as a desktop application. It looks like what you're seeing here. There's also Zotero. There's a whole slew of them, right? And then obviously the next thing to do here is when we do have paper reading sessions, and I think very first assignment here, trying to see if we can make it available next week or something. There's a little bit of research that is required, right? When you're told to go and synthesize a paper, that paper will have references, or that paper would have been cited by other papers, right? So your synthesis should take into account all those things. And the immediate question you ask yourself is, well, where do I find things to read, right? But we know sources of data. Google Scholar is your best bet here. Why? Well, because this thing indexes great literature. So literally everything is there, right? And I don't think we should be discussing details of how you filter information, how you look for the state of the art, if you will. But there are also curated lists that you should be aware of, right? So if you do your due diligence, you'll be able to come across certain platforms that will archive data for specific disciplines. In fact, you can do this for Google Scholar as well, right? When you come to Scholar, if I come here and I just say Scholar, for instance, what Google Scholar allows me to do is I can come here and I say, I want to look at metrics. I don't know how many of you have done this before. I know I have myself. And then observe. On the top publications here, you have the view all, right? On top here, you have categories. Once you go on view all, right? You click on this drop-down menu, and then you choose the field here. It could be life sciences and whatever, engineering and computer science. I don't know if there'll be health informatics here, but engineering and computer science. Under here, there are subcategories, right? Bioinformatics, computational biology, biomedical technology. I don't know if there's health informatics here. Maybe. No health informatics. Right, but you get the point. You can actually drill down on specific subdisciplines. In particular case, these are subdisciplines of computing, is it? Engineering and computer science. You can go back here and hopefully under life sciences, maybe. There could be, I don't know if there's health informatics here, but on subcategories, anything to do with health, nothing. I wonder if there's another subfield here, but it's just life sciences here. Health and medical sciences, right? And then under subcategories, biomedical technology, blah, 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 dermatology, health and medical sciences, medical, yeah, I don't know, but if you poke around here, you'll be able to narrow down public health, narrow down medical imaging, narrow down to a specific subfield. And usually when there's an assignment, it would be tied to a specific subfield anyway. So you can do this, and then what this does is it brings up an ordered list of publication venues ordered by index, H5 index. right? So the quality, in other words, is the quality of work you find here is much better than in here by looking at this metric here. Anyways, so there's that here. There are a series of places where you can find curated lists. In some instances, if you're lucky, there are places right here from Zambia where you find information published. Like there are people that do a lot of health-related things. They'll publish them to do with IT. They'll publish them in the Zambia ICT Journal, right? So if you just Google up Zambia ICT Journal, you'll have a sense of what is published there, right? Quite a bit here. And in fact, if we were to search, I'm pretty certain there's if we do a focus search, I'm pretty certain there's articles to do with health here. So I'm doing a focus search here, but just, if you notice, I'm searching for health here. You know, occupational health and safety information, targeting mental health assessments. This is good. View of a model for an electronic health. I don't know what that is here. Machine translation for improved access to healthcare. Quite a bit of stuff here. Risk prediction through deep learning classifiers for child, and what that is here. Assisted artificial intelligence medical diagnosis system. That's interesting. Yeah. Anyhow, so in other words, there are quite a number. The UNZA itself, I don't know if I mentioned this, but the UNZA publishes, not just on the repository, but we have 15 journals, right, on the online journal platform. These are all the journals. And out of these, there are some that focus on health. There's this Journal of Research in Nursing, Midwifery, and Health Sciences. There's a Journal of Agriculture and Biomedical Sciences, right? There's this journal, it's been a bit defunct here, the Journal of Preventive and Rehabilitative Medicine. But also, we have our very own, right? It's not affiliated with the UNZA, but Medical Journal of Zambia, .co.zm. You know, so quite a number of places, right, where you're looking for information, ideally, linked to what we're doing, or that would be associated with these things. Now, my advice on how to read a paper, which is supposed to be the focus of this part, is, and this will sound a bit of like a chicken egg problem, right? Go and read this classic called How to Read a Paper. There's actually a paper, How to Read a Paper. It's a short paper. And I like using what's called Keshav's approach, right? And what Keshav says, if you look at your typical research article that you'd be interested in synthesizing, it's made up of certain generic sections or aspects, right? If it's a long document, it will be like chapters or something. But if it's a paper, a journal article, or a conference proceeding paper, these will be sections. You have the title, the abstract, introduction, related work, implementation, evaluation, discussion, conclusion, and references. Now, what Keshav says is that you effectively take advantage of what he calls a 3-pass approach. In essence, for you to comprehensively understand the paper, you just go through it 3 times by focusing on certain key areas. And at the end of the 3rd phase, you understand everything about the paper. I implore you to just go and read. It's a short paper, right? How to Read a Paper by S. Keshav. Okay? And then he outlines in the paper, so in pass number 1, for instance, you just quickly you read the title, the entire abstract, which is like usually at most 500 words, the introduction, and then you just read the section headings, right? Or rather, you read the conclusion and references, you scan through them. In each pass, what it does is it tells you what you should expect in that pass. Like in pass number 1, the first time you read the paper, if you follow his guidelines, you'll be able to classify the paper, right? What type of paper is it? Is it an experimental paper? Is it a theory paper? And all those things, right? Context of the paper, the correctness, and its contributions, novelty of the paper, and whether it's clear or not. So he does this in the 3-pass approach here. I want to leave this to you to go and read Keshav's How to Read a Paper. And if you guys have questions when we meet over the weekend, we can have a discussion about this, really. Yeah, so how to read a paper, right? But the other trick here is that besides understanding what sort of approaches you can take, the only way you get better in terms of understanding how what people are writing about is when you read more. And there's an colleagues, there's an endless supply of things to read, right? I dare you to go to Anthropic or something, Cloud AI, and just ask Cloud, right? Mr. Cloud, right? How many journals, right? How many journals? Let's start with journals, right? How many? What is the approximate number of health informatics centric journals? What is the or just a current reference? A horrible prompt, I know, but effective enough to give us a number we're looking for. There's an endless supply. UNZA alone, right? It's 15 journals. What is this now? This thing is not even telling me what I want here. Okay, so it says research from 2010 he identified, not the number of papers. I'll just tell this thing, I need the approximate number of journals. These are all horrible prompts, I know, but I was just trying to prove a point to say there's a whole slew of, come on. One study, apparently, according to this one study, identified 48 health informatics journals or something. So there's an endless supply of this sort of stuff here. Okay. Anyway, so read, right? Reading is just quite nice, actually. And our very own here, there's a lot of quality stuff here. And these people are serious, right? A lot of good stuff here. They've been around for a very long time, these guys. If you look at the archives, the issues they have in their journal, it's insane. I don't know the proportion of articles they publish in their issues that will be linked to health informatics, but they've been around for a very long time, is it? Look at this, 2017. And how do we know how old the journal is? The issues is the volume, right? Because this journal is currently on volume 52. A volume is tied to a year, so meaning that apparently they've probably been publishing for 52 years or something. It's crazy. But anyway, so that's that. And then, so on how to read a paper, the key takeaway here is I'm pushing you to go and read the how to read a paper, or you can look up on, I guess, what has been published on how you read. Maybe you find the how to read a health informatics paper or something like that. There's also this other thing which is computer science centric. It's how to read a computer science research paper or something. You can take a look at it, but I highly recommend how to read a paper. You understand the 3-pass approach ideally. You won't go wrong ideally. And then I also wanted to remind us that you guys especially are doing a taught and dissertation masters. And I know a good number of you are funded, perhaps. Usually when you're funded, you look at it as, after all, it's not my money or something. But the amount of money you're paying to gain access to a lot of things, right? At some point you'll be assigned a supervisor. It's not just teaching here. It's these activities. And I implore you, I know you're busy people, but if you are to understand what we're doing at this level of study, really, if you want to seriously understand what is going on, you had better see beyond just attending class, right? That's not going to be sufficient here. So these activities I've been talking about here are quite important. There are always presentations at UNZA, right? Public lectures, they just send something here. There'll be a public lecture or something. If you have time, attend, right? There are oral exams. This time of the year, you have a whole slew of oral exams. This is in the School of Natural and Applied Sciences. In the School of Medicine or Public Health, there's a lot happening as well. So what you have to do is just cherry pick, right? And look at the things that you think are aligned with your future aspirations and things that are linked to what we're doing here. Look at this from public relations. Public relations always organizes things for us, right? There's a public lecture, so there's going to be a public lecture here. Invitation to a guest lecture. I don't know which person is from. It's gender related though. I have no idea what this is about here. Professor Kirk or something from Israel. You know, I saw this and I was thinking to myself, I wanted to find out from my colleagues. I don't know if they've already started posting with what's happening in Gaza and stuff. I wonder if academics in this part of the world think about those things. Oh, we're going to boycott. But you know, so there's, I don't know if you're part of this mailing list. If you're using a UNZA assigned email address, you will be. If not, remind me, I can facilitate so that you have access to a at cs.unza.zm account. You're entitled to that as well. And that gives you access to other resources that you will find useful, more especially in term 2 when you start doing your research work. Some of you are working on problems that will require that you gain access to compute resources, and you gain access to those resources for free with your UNZA assigned email address. So your course rep can remind me, or your class rep can remind me, and then we can, I don't know, we can facilitate that as well. You're supposed to have that thing created on your behalf. So anyways, so there's that, you know. The last bit here is more about activities, right? At the UNZA. You want to make sure that you're a part of these activities. There are always seminars, right? How many schools do we have? A ton of schools. What previously was the School of Medicine now has been fragmented into so many schools, right? And the way you learn, the way you become better at what you do, really, maybe some of you are just interested in that master's in health informatics, but the way that you learn actually is by listening to what people are talking about in relation to the state of the art, right? So seminars and seminars and seminars. I've become a better person by listening to other people talk about what they do myself. Endless supply of seminars, right? There are always proposal presentations. Very soon we'll have proposal presentations in the department for PhDs. You know, we have a number of PhDs and quite a number that are doing PhDs in health informatics, by the way. You know, so you want to attend in the event that you're thinking, you know, when I'm done with this master's, I wouldn't mind doing a PhD in health informatics or something like that, right? So please find time and do this. I've shared the schedule here. They are usually school-centric activities that are organized. So they're called seminar weeks. You want to keep an eye out on the calendar as well. So I was cruising here because this was not really important here, but I always feel it's important to just talk about this to remind you that your stay at UNZA in the next 2-3 years or so goes beyond just you attending classes. There are a series of activities. I normally send invitations. They will find you. There are some entities that will find you to go and attend events. Like I think there's a deep learning kind of thing happening soon, deep learning India or something. Students that I supervise almost always get some funding and then they travel like that. So be on the lookout and, you know, make sure you make the best out of your stay at UNZA or something. Listen, so when we meet, you know, colleagues, when we meet over the weekend, we shall immediately transition to this, okay? Module number 1. I don't know if there are any questions. I rushed through the last 2 parts. That was not the goal. The goal for this very first inaugural lecture was to, after the Administrivia, was to contextualize the course and show you the steps we're going to follow in the course, right? And then we're going to start when we meet next. Are there any questions or thoughts, clarifications that people need? I think people are tired. This is 2030 here. I want to say, you know, we started 30 minutes late. Let's go until 21 hours or something. But I think that's enough for today. So if there are no thoughts or questions, thank you very much. And good night. Thank you.
Thank you.